All right, well, welcome everybody. My name is Corey Lubring, and I am the PBR and coordinator at DO-Touch.NET. And thank you for joining us for this month's episode of Let's Talk About OMM Research. Before we begin, let's take a moment for the housekeeping rules of the webinar. Please feel free to introduce yourself in the chat and tell us where you are from. We also invite everyone to turn their cameras on so we can be united as an OMM research community. If you have technical issues during the webinar, please put a message in the chat. And if you have questions or comments during the presentation, please feel free to type them into the chat and address each other's questions and comments there as well. Also, we will have time for discussion and questions at the end of the presentation. And please keep in mind that this webinar is being recorded and will be placed on the public DO-Touch.NET YouTube channel. Today is our Let's Talk About OMM Research Journal Club, entitled Osteopathic Manipulative Treatment Decreases Hospital Stay and Healthcare Costs in the Neonatal Intensive Care Unit with Jane Johnson. Jane Johnson is a research assistant professor with the A.T. Still Research Institute at A.T. Still University in Kirksville, Missouri. She also serves as the associate director for DO-Touch.NET, a practice-based research network focused on osteopathic manipulative medicine. She received her BA in mathematics and an MA in statistics at the University of Missouri-Columbia. As a statistician, Ms. Johnson has supported numerous clinical and patient-centered research studies over the past 35 years, as well as pursuing her own research interests. Her current research interests include identifying patient and physician characteristics, which can be used to determine how well or poorly a patient will respond to osteopathic manipulative treatment, as well as comparing the effectiveness of osteopathic manipulative treatment to other conventional and alternative forms of treatment. Ms. Johnson has authored or co-authored 106 peer-reviewed research papers. So please help us welcome Jane Johnson.
Thanks, Corey. So while I'm sharing my screen, I will make my disclaimer that please remember that I'm a statistician. And not an osteopathic physician, as I'm sure you all of you are aware of. So I hope you've had the opportunity to review this article, and this was a little different for me on approaching this because it is a review article and not about a specific study. So please feel free to stop me at any time if you have comments, questions, if I said something wrong, whatever, okay? All right, so, okay, so something I saw one time talked about on a journal club to start out with the case presentation. So I, as a DO, have admitted twin baby girls who were 33 weeks gestational age to the NICU, and the babies weighed approximately 3.5 pounds when they were born. And one of the babies is having some signs of apnea. And so my question is, should I recommend OMT for one or both of these babies? So I went to my favorite search engine, Google Scholar, and I searched for OMT with preterm infants and OMT with neonatal, and came up with a couple of review articles. And so I picked the most recent one, this one by Rowland et al., because it came out last year. So let's look at an overview of this article. So one thing I thought they did, since this journal is not an osteopathic or manual medicine journal, the journal where it's published. I thought their overview about OMT and descriptions of some of the techniques that are commonly used to treat infants, I thought that was helpful for the audience. And then they go through a list of the evidence base supporting OMT in the NICU for addressing pneumonia, ankylosing, I don't know how to pronounce that word. So tongue tie. Feeding dysfunction.
I don't know how that's done, but I found something related. Do you want to know what letters are hard to pronounce with tongue tie?
Sorry, my Google is speaking to me.
Don't worry about it.
Gastrointestinal dysfunctions, weight concerns, and length of stay. Okay, so these are the different things that the authors addressed in the article, looking at the evidence base. Okay, and we'll start out with, this is their summary of the findings that they had. So OMT used in the NICU. This summary indicates that it reduces pneumonia, increases weight, reduces gastrointestinal dysfunctions, reduces problems from tongue tying, and increases feeding coordination. Okay, so let's look at each of these and the evidence that the authors presented. Okay, so in general, what's the importance and relevance of this article? Well, admissions to the NICU are approximately 10% of all births, and those admissions are primarily due to premature birth. The major concerns that these babies who are admitted to the NICU have are things like difficulty breastfeeding, difficulty in maintaining their growth, so they lose weight after they're born, and then being in the hospital, they're more susceptible to nosocomial infections, including respiratory and gastrointestinal infections. And then a major concern is also the cost of a baby being in the NICU. So let's start out with the evidence that they presented for pneumonia prevention in infants in the NICU. So once again, the importance and relevance of treating pneumonia or preventing pneumonia. First of all, infants and the elderly are at high risk for pneumonia, hospitalization. In infants, it's both aspiration and environmental causes of pneumonia. And they discussed the issues with antibiotic resistance, that we need treatments that are not just trying to throw antibiotics at the problem. Okay. All right, and so they went through the evidence of OMT for pneumonia, and it was all evidence about adults. And they concluded by saying, based on this evidence base for adults, a thorough evaluation of the benefits of integrating OMT in both neonates and infants admitted to the NICU with respiratory infections is clearly needed. So I'll go back to their little summary chart, which said, you know, OMT, NICU, reduced pneumonia. There's really no evidence of that. There's evidence that it works in adults, but not in the NICU. Okay. Any questions or comments on that? All right. Tongue tying. Okay. So the problems with tongue tying, 75% of neonates with tongue tying had difficulty latching onto the nipple. 35% had difficulty with sucking. And, you know, so this is a critical issue if they're not receiving nutritional support. 94%, now this study that they quoted only had 17 neonates in it. So, but 94% of them, so basically all but one, had cranial suture dysfunctions and restrictions, and all of them had occipital condylar dysfunction. Now, so here's a question for you all. What do those last two issues mean as far as infants thriving? Can somebody help me with that, because I'm not sure.
Well, it looks like Dr. Dean and I are the only clinicians on this call.
Crystal Martin.
Or maybe Chris and Crystal, I'm sorry. I apologize, Crystal. Didn't see you. Well, basically, these are just descriptions of types of dysfunction of the cranial biomechanics. And of course, the problem with that is that we've never been able to really objectify this with instruments, nor show, to the best of my knowledge, reliability in clinical exam. So basically, they're just saying their heads don't move in a variety of ways. And maybe they're, cranial suture dysfunctions, restrictions, any one of the cranial sutures could be involved. Occipital condylar dysfunction refers to the fact that the occiput is not fully fused, so there are suture-like phenomena in the four parts of the occiput in that stage of life. So did that answer your question, Jane?
Yeah, thank you. That was very helpful. All right. So those are areas that would be targets for OMT to try to correct some of these dysfunctions. Okay. And so the evidence base that they presented as far as OMT for treating tongue tie in neonates, there was a review of some case reports. There was one study that looked at adjunctive OMT in combination with regular lactation consultations, which showed that the adjunctive OMT was effective in improving latching when feeding. So none of these specifically address the tongue tying, just the results, the consequences of tongue tie. So there's a lack of specific evidence there, although there is some positive evidence on the effect of OMT on feeding, which we'll discuss shortly. Okay, like now. So feeding coordination, the inability to feed is a major cause of extended stays in the NICU. You know, because if the baby isn't able to feed, then they lose weight and they're not thriving, and so they have to stay in the NICU. Okay, so that seems pretty obvious. So that's why this is important. So they reported, the authors reported contradictory findings from 2 randomized controlled trials. One looked at, there were 35 subjects, 35 babies per group, and they found that OMT decreased the length of stay by 5 days. Okay. Another study had 64 babies per group, and they found no between group differences on feeding coordination. And I will quote the authors once again: additional well-constructed clinical trials should be conducted to verify the therapeutic benefits of OMT in the NICU. And once again, I'm going to point out that this first study that had a positive decrease in length of stay did not specifically address feeding as an outcome. Okay, they're using hospital length of stay. The authors of this review have used hospital length of stay being reduced as evidence that OMT has a positive effect on feeding. Okay, feeding coordination. Okay, but it's not a direct. The Kirksville group did not directly study feeding. Okay, so any questions on that? Because I would assume from my layperson's mind that there are also, although feeding coordination problems are a major cause of babies not being discharged from the NICU, it's probably not the only cause. Okay. Then Rowland et al. Discussed the evidence for gastrointestinal dysfunctions. Why is this important? Well, neonates frequently experience what they termed as stress-induced damage to the gastric mucosa. So there's regurgitation, vomiting, discharge, constipation, these types of issues. They looked at, they reported on 3 different studies. two of which were not randomized, and one was a randomized controlled trial. The first one, which was a prospective study, but it was non-randomized, actually found a 55% reduction in gastrointestinal dysfunction. Okay. But this was more of a comparative effectiveness study. So the osteopaths were in the hospital on Tuesdays and Thursdays, I think it was. And so the babies that came in on Tuesdays and Thursdays got OMT. The babies that came in on the other days did not. I don't know if there's any bias there, you know, difference between babies who come in on Tuesdays and Thursdays and babies who come in on other days, you know. But as a statistician, that's not ideal. You know, ideally you'd like to randomize them. But you know, 55% reduction compared to the control group, that seems pretty sizable. The other two studies, once again, are using the Rowland et al. Use length of stay to make a conclusion about gastrointestinal dysfunction. And so both this randomized controlled trial and this retrospective study both had a reduced length of stay. You know, one of them was 4 days, one of them was 12 days. It's important. Don't get me wrong there. It's important to have a reduced length of stay, but that really isn't specific to gastrointestinal dysfunction. Okay. All right. And then the final area that they discussed is the cost of medical care. And so, you know, we're all familiar with this, but they reported data from 2007, and I didn't go try to update this, but you can imagine it's not better. Hospital costs for preterm infants in 2007 were around $40,000 versus $1,000 for term infants. Okay. And NICU admission rates continue to increase. As we stated at the beginning, NICU admissions are about 10% of births. Okay. So, costs. So they related costs basically to length of stay. And so they had 3 studies that showed reduced length of stay in the NICU with OMT compared to controls. And each of the studies had different age groups or criteria. But bottom line is, all 3 of these studies showed a reduced length of stay, which does reduce costs. It's not clear to me that they list different reductions in costs given by each of these studies. It's not clear to me whether they factored in the cost of the OMT. But I would imagine, and this is me speaking off the top of my head, I would imagine that OMT costs a lot less than 4 days in the hospital. Yeah, Bill.
So your point's well taken that length of stay is being used as a proxy for cost. But the problem is that that's actually probably one of the most robust ways to measure effective costs, because costs can vary widely from region to region and hospital to hospital. And there are, of course, other things that might need to be in more rigorous studies controlled for, because there may be all kinds of other treatments being given as well. But the bottom line is fairly impressive that in 3 studies, there's a non-trivial reduction in length of stay. I mean, you're talking about 4 or 5 days. That's a pretty big deal in terms of the economics and the implications, non-specific implications, that these kids are getting healthier more quickly. So that's kind of the tension between length of stay versus actual cost. All depends on who sets the bloody, price for a given service or a given, whatever. So costs can be pretty misleading unless there's a lot more transparency about that and control of that.
Right. Absolutely. And one thing I don't think you included was, some of these studies are done internationally, not in the US. And so, and there's a huge discrepancy in costs between those, in the US and other places. So very good point. Thanks. Yeah, Marie.
And just to kind of add to the muddiness of the water, these would all be under a DRG or a case rate in the NICU. So it's hard to sift out where the OMM treatments are coming in, because it's all bundled up. You would have to look at each individual CPT code and diagnosis code to figure out, how much, how often, those kinds of things. So I think the cost is pretty unclear.
Very good. Yeah. So using length of stay is maybe the most objective way to assess costs. Okay. All right. So here's my conclusions based on this article of the implications for OMM research. Okay, we're going to start here. So we saw that there are no studies in neonates of the effect of OMT to treat and prevent respiratory infections. That all of the evidence comes from studies in adults. So there's studies needed there. There's contradictory findings on the therapeutic benefits of OMT for neonates with feeding dysfunctions. And as a matter of fact, the study that actually looked at feeding dysfunctions as an outcome variable had found no significant difference between the treatment and control group. So there's more research needed on that to try to resolve these contradictory findings. And then similarly on the gastrointestinal dysfunction, there are really no randomized controlled trials that look at gastrointestinal dysfunction as an outcome measure. So there was the one comparative effectiveness study. And then Roland and co-authors suggest that there's also a need for mechanistic studies that can be translated into clinical practice. Okay. So there's lots of room here based on what they've reported in this review article for osteopathic manipulative medicine research. Yes, Bill.
So I have a confession to make, which is I did not read this paper in advance. I spaced out the fact that this was Journal Club rather than one of our other presentations. But I have a couple comments about this. First of all, in reading the abstract and then looking at the references, I read the abstracts and I thought, oh my gosh, there's all this evidence of how wonderful this is that I wasn't aware of. And then you look at the references, and there are really only a few what look like high quality trials, that they were prospective and randomized and so forth. So this was an open access journal, and I'm not as familiar with this, but I'm wondering how well peer reviewed this was, because certainly some of the statements in the abstract look like, I guess, I would say they seem to lack intellectual rigor. And the other comment is about length of stay. I mean, now that it's been shown repeatedly, and it's not a day, it's 4 or 5 days, that actually is a really big deal. And that's sufficient motivation for more rigorous studies to try to drill down on why the length of stay is reduced. But I also have an anecdote that 2 or 3 of at least the clinicians in this audience might appreciate. So well over 40 years ago, when I was just starting out practice, I was being mentored by Robert Fulford, a famous osteopathic clinician associated with the cranial community. And we had a MD pediatrician at Tucson General Hospital who was very intrigued and open-minded and wanted Dr. Fulford to join the staff. So Dr. Fulford agreed to join the staff as long as myself or another young DO would accompany him to these sessions. And he was particularly being asked to care for children with cardiopulmonary distress that looked like they might be pre-sudden infant death syndrome. I mean, the connection, the causal connection between cardiopulmonary compromise and sudden infant death was not well established then, and I'm not sure it is now. Maybe Brian can comment about that. Well, it looked like all these kids that Dr. Fulford treated, their cardiopulmonary situation quieted down and they got out of the hospital a lot quicker than might have been anticipated. So I, being biased toward the value of osteopathic manipulative medicine, talked with the nurses about it. And their response was, well, the kids went home early, so we don't know. So they saw it in a 180 degrees different light than I saw it. They saw it as, well, these kids were going to go home early anyway. So how do we have any idea that Dr. Fulford did anything other than just voodoo? And so it is important that not only we show the length of stay improves, because we know that human touch itself is therapeutic. So just the time of touching these kids might be the causal factor, in which case skilled touch versus just human touch, isn't worth anything. And so the length of stay is a really big deal, but it is incumbent upon us to sort out the cause and effect causal chains of why this is happening.
Thanks, Bill. Amy.
Hi, I just wanted to make a comment off of Bill's comment. Seeing patients in the hospital, because I do OMM in the hospital, that's what I do. And what never ceases to amaze me is how OMM, nothing is working for 2 weeks, and then OMM is consulted and started, and then pneumonia, NICU babies, whatever it is, starts to turn around. And the answer is always that it would have happened anyway. And it is probably one of the more frustrating experiences of doing OMM in the hospital. And I think that's kind of a question I've had, is how do we educate, and can we ever do enough research to prove that what we do has merit and validity? Because I feel like it's constantly seen as everything but OMM, even though everything but OMM was done up to that point and it wasn't working. So I just don't know how do we ever do enough research to support what we see, or is that just inherent in our work?
Thank you. That's an excellent comment. And one of my responses is, and I see that Brian made the same comment in the chat, and that Marie was going to make the same comment, is this is why we've got to have randomized controlled trials, but we also have to have a good control condition, so we need to, for instance, in the MOPSI study, we had a light touch control and just conventional care control. But it came up, we're talking about elderly patients, and there wasn't really a difference between the light touch. There was very little difference between the light touch and the OMT group. And we get into maybe it was having somebody extra paying attention to them. Just being in the room and talking with them, or something like that, and so it's like, okay, so maybe we needed what's called an attention placebo, where somebody just comes in. So is it the touch, or is it the attention, or is it as Bill said, I think the term Bill used was skilled touch, so maybe we need 3 control groups, something like that. So it's a very, very good thought there, Amy.
Thanks for talking through that. That was interesting.
Thanks. Bill.
Yeah, I just want to double down that it's not, we know touch is healing, but we have a massive infrastructure in our schools and our profession, our professional identity is all wrapped up in the fact that OMT is something more than just touching people. It's skilled. And until we can show that those skills are necessarily causing the improvements that we see, as opposed to just merely touching people, we're still left out in left field. That's one comment. The other comment is, I agree with Marie and Brian. This is why we have to have higher quality studies. And one of the cores to that, and I'm going to toot my own horn here and also Brian's, but the objectification of somatic dysfunction. My work on the theoretical side and everything he's been doing now for years with advancing skills in osteopathy are toward that larger goal. Until we can have valid ways of confirming somatic dysfunction, and show that whatever results we see as, clinical outcomes are at least well correlated with the presence of somatic dysfunction, the resolution of somatic dysfunction due to our skilled touch, and then the clinical outcomes. Until we have all that, we're going to have we're still going to be, have all these missing pieces and all the very valid critique from skeptics.
But it seems like, designing a clinical trial with those kinds of components doesn't seem that overwhelming. And it sounds like we have the patience. So what is our barrier to do that type of research?
One of the barriers, are you talking about the validity?
Yeah, validating that, as Dr. Amy said, she gets consulted, then immediately the patient turns around and then they're like, oh, it's going to happen anyway. Well, why did you call me? So I think that if we can begin to really show that OMM was performed and the next day the patient started getting better, if we see that over time and we have different controls, that the patient who just got touched, because all the babies are getting touched, but how much are they getting touched? And then when you do the OMM, then they begin to turn around, and then we just need to prove that and publish that and get the word out. And how can we do that? What's the barriers to getting that done? Okay, somebody's responding here. Oh, Brian. So the issue is whether there's adequate sample because of the care variability. Can the case control study be done at multiple cities? Yes. Why not? Sounds like it's complex. I don't know that it is, because where all the DOs are, if they're in the clinical setting doing the OMM, we should be able to get those data. We have the PBRN, so all those sites, we should be able to get to those data.
Yeah, I think from there it's a matter of funding. Because that requires time on the part of the DO-Touch.NET members, whether it's getting them figuring out how to get their information out of their EMR, or hiring someone to help them get their information out of their EMR, things like that. So it's that basic part is a funding cost, is a funding issue. And someone who wants to take that on as a research study. So, Bill.
Well, I'm going to reiterate that even with doing this, even if we had a billionaire giving us the money and we did it prospectively, we still have the problem that the practice of OMT is very, very heterogeneous. The studies you've been doing just to try to label what people are doing reveals a lot of that. So it's highly operator dependent. And until you have an objective measure of whether operator A is actually effectively treating somatic dysfunction, whereas operator B may not be, you're still out in the dark. So having ways to objectify somatic dysfunction is the foundational issue. And it's very, very tough with the cranial model and on infants, but we've got to start with that. Until we had a blood pressure cuff, we couldn't objectify blood pressure, and we were just swimming in the dark. And we have to have tools like that for somatic dysfunction until any of this will really be meaningful.
So could we start with one? It seems like pneumonia may be a good place to start, because maybe, it's clear to see the the manipulative part and then the outcome. So could we take one disease state, pneumonia, and 1 or 2 therapeutic manipulations that go with that body part, and then that's the study, and then based on, you know, just touch from other disciplines or whatever, and look at that.
What I'm talking about is when we touch people to help with pneumonia, what are we influencing? Are we influencing the flow of lymphatic fluid? Are we changing the biomechanical properties of the chest or the whole entire respiratory mechanism? Until we know what the hell we're doing in a mechanistic way, you don't have a way to measure whether one practitioner or another is doing anything.
So we don't have, and I'm sorry, I'm new to all this. We don't have that baseline data.
Not in my opinion, and I know you are new to this, Marie, and that's part of why I'm blowing off some steam here to at least in my own perspective, educate you, because well, I don't want to go into it anymore right now, but that we've got to have tools for objectifying somatic dysfunction.
All right. We're going to bring it back to Jane to continue the presentation, because we are running low on time and everything. So we want to make sure that she has time to finish what she wanted to give in the presentation before we reach our limit. Excellent discussion.
And this certainly what research we want to do in the future is and who's going to take those projects on is something that as a whole DO-Touch.NET needs to work on. So all right, well, so I'm going to bring you back to the clinical application of this article again, and going back to my made up case presentation about the twin baby girls who were 33 weeks gestational age that I admitted to the NICU. And just a reminder, they weighed about 3.5 pounds, and one of the babies is having signs of some signs of apnea. And so based on what I found in this article, should I recommend OMT for one or both of these babies? And so once again, I'm going to turn this over to you all. My non-clinical opinion is based purely on the length of stay results that we saw in this article, and the safety of OMT, which I didn't discuss, but they do mention in the article about that OMT is considered safe for neonates. I mean, I think that, you know, recommending OMT wouldn't hurt, and that's my professional statistician opinion. Does anyone else have any comments on that?
Well, I mean, from a medical necessity standpoint, you want to, you know, make sure that you're on solid ground when you're prescribing something. So I'm with Dr. Bill, like where's the clinical data that this would be helpful?
Bill?
Well, saying it doesn't hurt is basically as Amy said, the state of the art. You know, they're spinning their wheels for 2 weeks, so they don't know what else to do, so they call her in. And while that's the practical reality of what's happening in modern life, and it's better than it was 50 years ago, where, you know, there was active hostility towards so much of this in so many settings, you know, it's barely a toe in the door. I mean, just because it doesn't hurt, it still has to be paid for. And we still have a massive infrastructure that defines our profession. And we ask the students to go through all the training. And I mean, it's, you know, saying it doesn't hurt is okay, but even then, we know that it has risks. They may be extremely small compared to all kinds of other medical interventions, but it's not risk-free. So, I mean, I've been there, done that in allopathic settings for years. Well, you guys, you know, it barely, you know, it's very safe, but even if there's a 1 in a million chance that something serious could happen, until you prove that it really works, and it works because of what you did, then it's not medically justified. Now, that's a little disingenuous in many respects, given the risks of needles, knives, and drugs and hospitalizations, but it's still the reality of medical consciousness.
All right. Well, unfortunately, we have come up with time for our presentation and discussion time today. We had great discussion during the presentation, so I want to thank Jane for integrating that into her presentation. And I want to thank everyone for being so active and participating with discussion during the presentation today. Don't forget that this webinar recording will be placed on the DO-Touch.NET YouTube channel, where any discussion can continue within the comments section and everything. And watch your email for an announcement for when the next recording will be available. And we want to thank Jane Johnson for a wonderful presentation today. And the reminder that our next Let's Talk About OMM Research session episode will be a network update that will be on July 21st. And we will look forward to seeing everyone then.
Thank you.
Thank you, everyone. Awesome job, Jane.